Good afternoon. I hope all of you enjoyed lunch today. I'm sure it was better than yesterday. Till now, in this conference, we've been talking of use of lasers in healing. And Dr. Weber tells me that now he's going to show us how he's going to be using lasers in killing. Welcome, Dr. Weber.
Wait for the picture. Coming, the presentation? Yeah, okay. Yeah, thank you very much. And I hope I can tell you something very new today and something really amazing from our work in the last 2 or 3 years. Before I start, let me tell you some words about my personal history. Maybe you ask yourself, why is this man speaking about laser needle acupuncture, intravenous laser and stem cells, and now about cancers? My history is I had a good education in the university, studied chemistry and biochemistry, finished this, and later I had a very good education in Göttingen University with my medical examination. I had a brilliant education in gastroenterology and cardiology. I learned all these invasive procedures like endoscopy, interventional cardiology, and 1988 I've set up my own clinic without any laser therapy. It was not interesting at this time, and we had a lot of patients, thousands of patients in all fields of medicine, orthopedic ones, gastroenterology, cardiology, and of course I made a lot of chemotherapies in cancer patients myself. But I think if you work as a clinician in your clinic long time, 10, 20 years, the longer you work in this field on your chronic patients, the more you see the limitations of normal medicine. And I know many doctors, it's all the same thing. After 10, 20 years, they start for looking for something else. Maybe they move to natural medicine, what I also did. I made an education. And in 1990, about acupuncture became very famous in Germany. So I learned acupuncture to have a better offer for my patients for pain management. Started with needles. And then I had a great chance in 1995. I met a professor for physics from the university, and he was a specialist for lasers. And then we had the first idea to set up a laser system for acupuncture. And we wanted to set up a fiber optic system so that we could treat many points at the same time together. And when you move in this field, and I wanted to get grants from the government, and I got it, you have, of course, to read all the literature. And if you review all the literature, then you find many publications from the recent last century about intravenous laser and everything. So I got very interested in this field, and then we have set up this intravenous laser. And then we had the intervention technology. We had catheters and needles, and from this we came to interstitial and intraarticular laser. I was on a conference in Orlando in America, and two neurosurgeons came and they said to me, you have lasers and catheters, why you not put it on the spine directly to use the healing effect of laser light? Yeah, the idea came from other people, so we did it. And then, of course, we have a lot of cancer patients. And if you look in the literature for lasers, you find many, many publications about photodynamic therapy. So I got interested in this field. And then we started about 5 years ago with the first photodynamic treatment. And this field is moving so quickly. And now we can use all the different methods. We can combine with interstitial, with intravenous. We can make the pain management with laser needles. And we can attract the cancers. Yeah, of course, all lectures here showed us the healing effect of laser light. But of low-level lasers. We speak about low-level lasers, not of hard lasers. Of course, we can coagulate and destroy lasers with hard lasers. We speak about low-level lasers. But we can use low-level lasers also destroy cancers. So if you look in the current laser books, everywhere is written, no low-power lasers in cancer patients, because you can stimulate cancer growth. Of course, it's true. And if somebody comes in your clinic and has maybe a dark spot on the skin, don't use a laser and hope you can remove it. Yeah? You should not do it. That's really wrong. But we can do it, but we need something what we can stimulate to destroy cancer cells. So that's something what I want to show you today in this lecture. Oh, hopefully this works. Not working. Let me check once more. Yeah. So I told you yesterday and the day before about the different fiber optics laser applications. First of all, we can use lasers for external treatment, only to repeating this in some slides. This for external treatment, the so-called laser needles, what we can use for pain, of course. That's are the laser needles with all the different colors. Then we have set up this intravenous laser therapy with all different colors, mainly to stimulate the immune system. That's are the available lasers, what we have set up in the last years, the full spectrum, including infrared. Interestingly, we heard many lectures showing that infrared is able to penetrate the bone, what is very important for bone cancer and brain cancer. I showed you the interstitial laser therapy, what we can use for maybe for arthritis or maybe for spinal problems. We can put them in joints. But now we are also able to put them in cancers, for example. Yeah? So we can use this interstitial therapy very well to bring laser light deeper into the body. Yeah, what is photodynamic therapy? It is not difficult to understand, and I think you know already about what I'm speaking. If you put this word in Google, you will find thousands of publications about this. Photodynamic therapy is regarded as one of the most interesting and promising approaches in the treatment of cancers. The principle is the stimulation of a light-sensitive drug which is injected into the bloodstream and accumulates in cancer cells. Tumor tissue is subsequently destroyed by irradiation with light, low-power laser light normally, of appropriate wavelength according to the absorption of spectra of the various photosensitizers. The basic principle behind this mechanism is the development of radical oxygen species. When you read this, this looks very promising, but immediately you will read also this one. However, up to today, PDT, photodynamic therapy, is limited to cancer treatment of only superficial cancers because we are not able to bring the laser beam in a sufficient concentration deeper into the body. So photodynamic therapy is nothing what I have invented. It's already done for many years in many, many clinics, university clinics, and there is no doubt about that it's working. The problem, however, is we only use lasers, we can only use lasers on the surface. Yeah, so it is for skin cancer, maybe for superficial cancers in bronchial system, esophagus or stomach or gut or anywhere where it's superficial. Yeah, that's the principle behind this. So we have a photosensitizer, what we can maybe give as a cream on the skin, or we can inject it. It will accumulate in the cancer cell. We need then the light for stimulation of this cell, and then we activate the tissue oxygen to produce free oxygen radicals, and this is our cancer drug, the oxygen radical. So we see already the requirements. We need good light, what we can apply very close to the tumor, otherwise it doesn't work. We need a good photosensitizer, which is very specific and only goes in cancer cells and not in healthy cells, because we don't want to destroy them. And then we need enough oxygen in the tissue, otherwise also it will not work. This is the principle. So this is the photosensitizer on the ground state, and then we can activate it with light. So there are different ways what can happen. The light can come back quickly as a so-called fluorescence, maybe in another wavelength, and we can use this fluorescence for tumor diagnostics. Also, we have an intermediate state, but what we want to achieve, or where we want to go, is the singlet oxygen, what destroys the cancer at the end. So what is the mechanism then, what happens on a tumor if we bring enough oxygen radicals? First of all, we have an endothelial effect with the microvascular shutdown, leading to tumor hypoxia and starvation of the tumor. Then we have a direct in the organelles of the tumor, which leads to apoptosis and necrosis. And also we induce an artificial inflammation leading to a non-specific and later to specific immunity. So the mechanism is, first of all, selective targeting of tumor cells. We have minimal side effects if we have good photosensitizers, no resistance after repeated treatments, in contrast to chemotherapy, tumoral vascular shutdown by thrombosis and hemorrhage, induction of local inflammation, and leading also to immune activation. Very important is that we bring enough energy right into the whole tumor tissue, and maybe not only in the center. Otherwise, the energy is very low at the edge, and maybe will even stimulate tumor growth. Yeah, this looks complicated, but it is not really complicated. That is what happened in PDT, and that is just the opposite what we are doing with chemotherapy. So we have the tumor cell, we have the photosensitizer, which will be integrated maybe by endocytosis in the tumor cell. We give the right light, we produce the reactive oxygen species, then we break down the tumor cell, and then we have phagocytosis, and the broken tumor tissue, the body can start to make its immunity as a maturation of dendritic cells with tumor antigens, a microvascular shutdown of the tumors supplying blood vessels. So this is a nice process because it leads to an increased immunity, and that's the opposite just from chemotherapy. I will not say that chemotherapy is wrong. Also, chemo drugs are working, and I will show you later that we also use chemo drugs in complicated cases, especially in stage 4 cancers, but also we use them in a different way. Let's look first on photosensitizers. It is not difficult to understand. Photosensitizers which are on the market are normally derivatives from the porphyrin molecule. You know this. It's either from the Hem molecule, you remove the iron out of the center, you have a hematoporphyrin derivative. Or you use the chlorophyll, which is the same molecule. You remove the magnesium from the center, you have a chlorine. It's very easy to understand. All the normal photosensitizers which are on the market are porphyrin derivatives, but without a central metal atom in the middle. And we have already photosensitizers on the market, and you see most of them are hematoporphyrin derivatives. The main substance which is approved everywhere is the so-called photophrine. Photophrine is a terrible substance. I hate it personally, although we have many publications about it because it's not very specific. You have to inject it, you have to wait 48 hours till you can give the light therapy. You have to stay for weeks inside because it leads to a toxicity of light, so you cannot go in the sunshine anymore, and it's quite expensive. So a dose costs nearly $4,000 or $5,000. Then we have different chlorophyll derivatives. These substances are on the market, but I tried many of them, but really I'm not happy with them. And you see, this therapy is already approved on superficial tumors. Yeah, actinic keratosis, basal cell carcinomas on the skin, Barrett's esophagus dysplasia, cervical cancer, good results, but everything only superficial, maybe in the first 2, 3, up to 5 millimeters in or below the skin. So we are not able to treat a liver cancer or pancreatic cancer, kidney or anything else on the body. So this is the photosensitizers what we are using today. There's a new chlorophyll derivative, we call it chlorine E6. We will speak later about liposomal indocyanine green, but also we have very good natural photosensitizers. There are good studies about this. Hypericin from the St. John's Wort plant was used already in pancreatic cancer in Los Angeles University with good results, but it works with yellow laser. So therefore we had to set up a yellow laser. Curcumin curcuma is a wonderful photosensor, well known in cancer therapy, works with blue laser. And there's another one, that's riboflavin, that's vitamin B2, works very well against microorganisms and viruses, for example, in hepatitis. Because the PDT does not only destroy cancer cells, also you can destroy viruses, microorganisms, it's used for malaria. We have a study running in India in the moment in your country with malaria treatment with photosensitizers. Yeah, and here you see chemo drugs. We can use chemo drugs today in a different way. We can use them as photosensitizers in a low dose. If we know the absorption spectra of doxorubicin, even liposomal, mitoxantrone, and 5-FU, cisplatin, paclitaxel, you see also we can stimulate them with light. That means we can give them in a much lower doses, maybe 10 or 20%, make them a lot more effective. We have no immune suppression, even they enhance the immune system in combination with the other photosensitizers. I'll show you later some data about this. So this is a partial part of the porphyrin molecule. We use this in skin cancer treatment. This has a long history, is used, approved everywhere, even in the US. The name is Levulan. It's a cream, quite expensive. Here you see the absorption spectrum, blue, a little bit green, and red light, 635. And interestingly, if you put it on a maybe basalioma and after 3 hours you irradiate with blue light, the light comes back in a red fluorescence. So you can use it for PDD, photodynamic diagnostics. So that's also an interesting field. So, and it's a very easy treatment and it works well. So you put the cream on the skin, you let it work for 3 hours, you irradiate for 10-15 minutes, and then most you can remove it. This is a patient what I treated. You can do it several times. This was a big basalioma. The surgeon wanted to cut out a big piece here. We did it several times. You always get very good results. So before you send somebody to an operation and you have the right laser, it's really not difficult. You always get good results. So that's topical photodynamic therapy. That's well approved. But how can we treat inner cancers with low power lasers? We started 3 years ago with this substance, chlorine E6, was made in a very pure form from a company in Germany. Very specific, nearly no side effect, has a wonderful kinetic, so injected after 2 days is out of the body, the people can go in the sunshine again, accumulates 99% only in tumor cells and not in healthy cells. So we use this substance for about 3 years. You see it's again a porphyrin derivative here with 3 carboxyl groups as a 3 sodium salt. This makes it water soluble. Yeah, and the normal chlorophyll is not water soluble. It's made from plants here, and then from tons of plants you get 30 milligram ampoules. So normally we give 1.5 milligram per kilogram body weight intravenously. Here you see the maximum absorption. It's around 660. Yeah, so you cannot work with infrared laser. It's around 660 here. And the principle is always the same. Now we inject it. It stays about 1 hour in the blood circulation. And the idea what we did then we have already the needle inside. We irradiate the blood intravenously with the right laser to remove circulating tumor cells and also tumor stem cells. It works also very well, for example, with hypericin. About 3 hours later, it's accumulated to 99% on the tumor, and then it will be irradiated about 900 to 1000 joule, about 15 minutes, and then if it's optimal, you reach apoptosis and necrosis. But still, the problem remains. If you look at the photo-free, the one what we have on the market now, the maximum what you can reach maybe 0.5 to 1 centimeter in the depth of the tissue. It is a little bit increased with the chlorine, maybe to 2 centimeters, but anyway, not enough to reach a pancreatic cancer or something else in the body. So we still have the limitations. So how we can improve this? So if something is little bit below the skin, maybe only 1 centimeter, maybe lymph node in breast cancer, we can do it from outside. If it's deeper, and if you increase the power, you only burn the skin and you get a wound and ulceration. This was a publication what I read. This was so fascinating by me. This was published in the European Radiology Journal from Professor Vogel. Professor Vogel is chief of the Department of Interventional Oncology in the University of Frankfurt. He's the president of the European Radiology Society. In 2005, they already made a fiber optics like this one and put it in liver metastasis, here, and showed here after 2 weeks 5 catheters they put inside. They gave a photofilm before, and they could show they could remove the liver metastasis. In this moment, I thought for myself, we have this technology. Why did this not spread on the market then in the next years? Because there are no devices on the market. But then I thought for myself, we have the interstitial technology, so we can use this. So we started in our own patients. And this is a very famous violinist from the London Symphony Orchestra with lymph nodes after breast cancer. And we could treat her very well. So we put the needles then below the skin, because you know the skin absorbs more than 50% of the laser light already. And it's a great attenuation, and then you have not enough laser light in the tissue. Especially red light is even less effective than infrared light. But with this one, in these cases of cancers, we had really good success with the chlorine E6. See some cases, this was a mouth bottom cancer with some lymph nodes, or here a larynx cancer. So we are doing all these endoscopies. So this patient has a larynx cancer which spread into the soft tissue of the neck. So we made it endoscopically with this fiber optics and also put needles here inside like this one, and it worked quite well. This is a patient with melanoma metastasis, only that you see the procedures, or thyroid cancer with multiple nodes. Also, we have good success. This lady suffered from mediastinal lymph nodes after breast cancer. So we put the needles maybe 0.5 centimeters through the skin, and then we inject some saline solution for better light spreading, the same procedure what we are doing in interstitial therapy, and then irradiate with red laser. Mostly we use 100 milliwatt, and these are laser needles which are very concentrated, and you see the spreading of the light. Yeah, another patient with this. This was a patient from Tucson in Arizona with a big lung cancer. She was very, very slim. The cancer was between the arteries here close to the heart, so they couldn't operate it, and we could reduce the size of the tumor for about 50%, and she survived for 3 years already, so this was also quite good success. This was a 2-centimeter breast cancer. Now after 3 years, absolutely gone. So in such cases we had good success. Here you see the spreading of the light. Show this picture already. This was a patient from San Francisco, but this was very bad cancer, and she suffered from brain metastasis. And with the breast it went quite well, and she's still alive after 1 year, but she has a big problem with her brain metastasis, and the problem is she cannot come back in the moment that I could treat her maybe with indocyanine green. Yeah, pancreatic cancer, also we had some cases with some good success, but not all the time. Peritoneal carcinosis, so if people have ascites, we put the needle right into the water inside. We also can inject the photosensitizer directly inside, or even in pleural infusions, we can, maybe in mesothelioma, we can inject the photosensitizers and irradiate in the pleura or in the peritoneum. Or liver, what we tried, put it right to the liver capsule, but the penetration of red light in the liver is not good. So I tried myself. If you go to the butcher and buy a liver and put a laser needle with red laser inside, the spreading is maybe 2 centimeters. So if you have a patient with multiple liver metastases, you will not be successful. We had great success now in urology. We have set up specific catheters with a hole at the end so that we can put fiber optics through, and we block them in the bladder. And this is a specific fiber optic, similar like I showed you from Vogel. It has a circular irradiation at the end, and we put it here on a 500 milliwatt red laser. We also have a 2000 milliwatt red laser, and you can put this right in the catheter, right into the prostate, and then irradiate the prostate from inside, or maybe the bladder from inside, with red laser, hypericin with yellow laser, or curcumin with blue laser. There's another fiber optics with a ball at the end with a spheric irradiation. So same thing, what you can use very well in the bladder. This is a typical bladder patient. It's a non-invasive treatment. We give the photosensitizer, we wait for some hours, put only the 12 Sharia catheter inside, which is really not difficult and not painful, put the fiber optics inside, ultrasound guided, and then give the different colors. Yeah, you can see even the red light then from outside. And believe me, if it's a superficial bladder cancer, with one treatment, chlorine-6, more than 90% healing rate in one treatment. We have great success with this. However, not if it's gone maybe through the bladder wall in the surrounding tissue, it's more difficult. But if it's superficial, here you see a PET scan here with this patient half year later, 3 years ago. It's working very well. We also are doing all these endoscopies. That's my specialty, esophagus, colon, and stomach. So we treat a lot of esophageal cancer patients, but with chlorine-6, if the cancer is quite big, it's difficult. If it's superficial, it goes quite well with chlorine-6. This is a patient from Switzerland with a stenosis. 3 years later, he's now still alive, what was very surprising for me. Yeah, however, the big problem, we have limited success by using red lasers only. Limited penetration depth. If the tumor is bigger maybe than 2 centimeters, it's difficult. Otherwise, you get burning and ulceration if you give overdosage. Light sensitivity is still a problem. No good success if patients have multiple liver metastasis. Limited success for bone metastasis, because the red laser, you cannot bring it in the bone for bone metastasis, and especially you cannot treat brain tumors successfully. We have a solution. Solution is a substance which is on the market worldwide for more than 50 years. It was approved in Mayo Clinic In the United States, already 1958, is an approved US substance, is indocyanine green. It's a nearly non-toxic substance, and it's used for fluorescence diagnostics, so you can inject it. You can then show by fluorescence with a special infrared light the blood flow in the eyes or in heart or liver, especially also in open surgery. And it's a wonderful photosensitizer because it's the first one which works with infrared light. That's what everybody's looking for. Infrared goes much deeper, goes through bones and everything. Yeah, but the problem is indocyanine green. You can inject it even in children, no problem, but it leaves the body after 30 minutes, it's gone. Yeah, it's quickly removed out of the body. So we have to change something. How can we keep it in the body? Pure indocyanine green binds to plasma proteins removed from the body quickly. We have to put it in liposomes. We have to make a better drug delivery, nanoparticles, you know. And this is the molecule here, and this is the absorption spectra, 810 nanometers, what we are using everywhere. And a new option for improved tumor targeting and uptake is the formulation of ICG in nanoparticles like liposomes. Yeah? So if we inject the ICG in liposomes, it will stay in the bloodstream. It will not go out of the body. And then passively, maybe time by time, it will be accumulated in tumor cells. So you see the photosensitizer normally is not going easily in the tumor cell, but in liposomes, but it takes time. It's not going in within some minutes or hours. This is a newer publication about pharmacokinetics of liposomal ICG. So they injected it in mice, and after 24 hours they can see already the accumulation in the leg, and there's also a huge accumulation in the liver, quickly. And what we did not know in the beginning, because everything is not new, it's showing that ICG even takes up to 5 days. Still it's accumulated in the tumor. Now we make the treatments longer. And the big advantage is we need only one shot. And it costs only 1,600 euros. And we can treat patients maybe for 2 weeks. Yeah? So the big advantage is ICG absorbs infrared light, has the highest penetration and depth in the tissue. It produces a lot of singlet oxygen. And we have something else. We have an increase of temperature. And we know that cancer cells are a lot more sensitive for heat than healthy cells. Therefore, people make hypothermia, for example. And we have a so-called overheating effect additionally to the photodynamic effect. So we call it photothermoablation therapy. Yeah? And this is also shown in a newer publication showing that the liposomal ICG brings about 3 degrees more temperature, yeah, in comparison maybe to saline alone. And here also you see, after, in the beginning, if you give only saline, this is a picture which shows cancer growth, and if you're in mice where they implanted cancers, if you give saline only, the tumor is still growing and growing. And this is irradiation with ICG for some hours, for a day, or maybe for some weeks. There you see there's a great suppression of tumor growing and necrosis. This is indocyanine green. It's a light green substance, and this is a pancreatic cancer patient. I treated him 1.5 years ago. He's still in very, very good health. And the best you can see the effects on the colon. This is one of my colon cancer patients. Here you see the nodes in the rectum about 50 centimeters from the anus. We give ICG, we switch to infrared laser. You see fluorescence here. And amazingly, 1 or 2 days later, you can see light melting away the cancers. We have liver cancer patients with 3 centimeters liver metastasis. You check them 4 weeks later, it's only a cyst. There's really a melting effect. This substance is such amazing. So we are so happy that we have this today. And I will show you one case report later. Yeah, what are we using additionally? There are some, of course, some wonderful photosensitizers in the nature. Hypericin from St. John's wort is a wonderful substance. This is the chemical structure and absorbs exactly 589 yellow light. So we developed a strong yellow laser for this substance. And this is now available from a big pharmacy in Frankfurt in a pure solution for infusion without any side effect. And then later, after some hours, you can treat with yellow light, even interstitially. Another wonderful substance is curcumin, well known, curcuma powder. It is assumed there are less cancers in India because they have so much curcuma in the food. You see the absorption spectrum exactly 447, that's blue light. Here and this is the substance which is also available as an infusion, and then you can use both even for interstitial therapy. So we use chlorine today with red laser, indocyanine with infrared laser, hypericin with yellow, curcumin with blue, and now we are working on virus and tropical diseases with riboflavin, also with blue lasers. However, still we have problems. Small single tumors are ideal for PDT treatment alone. But PDT alone is normally not effective in big tumors, widely spreading tumors, and multiple metastases. So here we have to think about the partner therapy. What can we do else? Yeah, we need something to stop tumor regrowth. We need something else on the side. So we need combination therapy. We can combine with traditional chemotherapy. This is done already. It works. However, we have still the problem with immune suppression. We give these people maybe on the side some intravenous laser, then you can reduce the side effect. We can combine with light-sensitive chemodrugs, using chemodrugs as photosensitizers. We can use with antioxidants, already done. Angiogenesis inhibitors like Avastin, combination with COX-2 inhibitors, antibodies, different natural compounds, immunotherapy. So there's a lot of different options. Cancer therapy is always a complex treatment. It's not only one thing which helps all the time. You can find this in the literature. 5-fluorouracil, which is a common chemodrug everywhere, especially in gastroenterology, can be enhanced up to 100 times by ultraviolet laser. 5-FU absorbs 350 ultraviolet. We have no lasers in this moment, so we lead the infusion normally through an ultraviolet providing device. Because this is the pyrimidine, and 5-FU can be, by ultraviolet light, be transformed in another form which is about 100 times more effective than the normal fluorouracil. So we can use it in maybe a 20% dose without any side effect. Mitoxantrone is a common photosensitizer, is a blue substance, is very good against ovarian cancer. Strong chemo photosensitizer. Nice publications about this. This is mitoxantrone. And this is the substance, and we measured ourselves the absorption spectra, and you see exactly yellow light and 630 red light. And what we are doing, we have set up new fiber optic needles. You see, this is a 3-Lurlock Y needle, so we can give the infusion, and we can stimulate during infusion already when it's running in the body with the right laser light. Doxorubicin, liposomal form, like the indocyanine, works 3 weeks in the body. Widely used photosensitizers, is an orange solution and also stimulated by visible light. Can be enhanced by liposomal delivery also. We call it Doxil. In Germany it's on the market as Celix. This is liposomal doxorubicin. We measured the absorption spectra, 447, like curcumin. So we give it mostly in combination with curcumin and can stimulate again with the Y needle with the right blue laser already during injection in the body. I will only show you one case report because this is a very, very bad case, and I'm so proud about this because it's a doctor. She's a doctor, she's a lady, I know her very well. She's working with intravenous laser for a long time. And then she came to me about 3 years ago and developed ovarian cancer, already metastasized, yeah? In ultrasound, PET scan, ovarian cancer, peritoneal carcinosis, ascites, metastasis in pelvic, perihepatic. So normally this patient has no chance, yeah? But she came and said, can you not use your therapy? Yeah, she had already ascites inside. I punctured this and gave interstitial needles for the ovarian cancer. And I show you, she put this together for me, how this worked. You see, we started already in March 2013, 3 years ago. And in the beginning, we used only chlorine E6 intravenously. I injected also intraperitoneally. And it was stable for nearly 1 year. And then it went up again. Then we had but suddenly it was really an explosion. She developed on both sides 10 centimeters polycystic ovarian cancer. You could even feel it with your hand. And at this time, then I thought maybe we give her the additional chemo drug. And the chemo drug is the black one. Here you can see the additional chemo drug. And the white ones, what is difficult to see, we started in January this year because that was the first time where the liposomal indocyanine was available, and then you see the combination of mitoxantrone, liposomal indocyanine green. We did not give the chlorinase-6 anymore. The tumor markers were 900 here 125. It's now 3 months ago 45, and just yesterday I got an email from her, it's down to 35. Everything disappeared. So it's such an amazing case. I will not say we can cure everybody, but this is a typical case. Yeah, and also we use this one. One of the key is to bring enough oxygen in the body. Of course, you can breathe oxygen, but you can never go more than 100%. How can we do? We put the people in the hyperbaric chamber. We can increase the oxygen maybe 20 times in the blood and in the tissue, and also this seems to be quite successful. So our new strategy is now to put everything together is photodynamic therapy using lipid-ICG, chlorinase-6, hypericin curcumin externally with external interstitial intratumoral irradiation, hyperbaric oxygen, low-dose chemotherapy in stage 4 cases using chemo drugs as photosensitizers. Of course, maybe followed up by immune therapy. Anyway, laser blood irradiation, what we always combine. Then, of course, there's a lot of new immune therapies, macrophage activating factors. There's a new cucumber derivative from New Zealand. We have centers in Germany, they work with dendritic cells. We heard already a lecture today, dendritic cells, maybe stem cell activation also is an interesting field, oncolytic viruses, so there's a lot of new developments. I was on the World Cancer Conference in Shanghai in May, and it was one day only about immunotherapy, a lot of things in development. Yeah, this is from India. I found this picture today on my computer. This is my son Robert, and this is Dr. Bansal. Close to Delhi, he has a clinic, and they are performing a study in the moment with malaria. They give riboflavin and then treat with blue laser here. So this is still a running study. You see, we are already active in India. And it was already published here in an Indian newspaper. This was some months ago. So let's see what happens in the next time. Yeah, and sometimes people bring me also dogs. I'm not a veterinary doctor. And my sister, she's working in the for health organization for dogs. So this dog had an inner ear cancer which was growing already to the brain, and they asked me, can you not do something? We treated with chlorinase-6. This was a time I had no ICG, maybe then with better results, but we have chlorinase-6 also for animals. We have a big animal clinic in Bangkok working with PDT all the time, made an anesthesia, 500 milliwatt red lasers, external radiation, interstitial radiation, and see here again, and after 6 weeks a fantastic healing rate. So I have to admit that the dog got a recurrence later after 3 months and anyway passed away, but the preliminary success was there. And yeah, I wouldn't like to finish at this point, but I want to tell you that we are organizing every year a big international conference about laser therapy in Germany. Last year with 180 doctors from 23 nations, and I would like to invite you all and also our good speakers to give lectures or attend on our conference. And next year will be the first week of June, maybe end of May. The date is not yet fixed, but if you look on the website here, you will find all the information about our activities. We give seminars in November in Bangkok, in Japan, in Taiwan, in Malaysia. Maybe also here another one, a practical seminar here in Bangalore, maybe on the way to Asia. And yeah, again, this dog wants to say goodbye to you, and thank you very much for your attention. Yeah, any questions? It is a new field, but it's an amazing field, because believe me, this therapy has really no side effects. We are treating young children, 2 years, with brain cancers now, retinoblastomas, and we haven't seen, especially now with this ICG, any side effect, no light sensitivity. So that's really my great hope for the future, that we can do something good for these people.
Thank you, Dr. Weber. It's a wonderful talk. PDT has been there in this field for a long time, cancer therapy, right? Toxicity is the main concern, because the necrotic effect of this has, it is a main concern. There's a lot of pain involved, And have you seen that with patients? How do you address it?
Yeah, that's true. Especially with the old photos, and the photo-free made a lot of pain. You know, give you a lot of energy. It's very painful with people. Chlorine was already better, and you have no such big collateral damage, you know, around the cancer. But even with chlorine, sometimes it's very painful. This is completely different to the ICG. The ICG nearly doesn't make any pain, and I think the reaction, the photoelectric reaction, is going slowly. You know, it's not so that the tumor tissue is damaged within some hours or one day. It's a slow reaction working for several days or maybe some weeks, so that the body also has time enough to remove all this toxic broken tissue. So I think we have a very good substance in the moment.
Have they looked at the molecular cellular mechanism behind this? Is it perhaps an apoptotic mechanism than a necrotic mechanism?
Yeah, I think maybe it's more apoptotic, because with the chlorine, if you have an esophageal cancer, yeah, and I make the endoscopy, give the chlorine, put the fiber optics, I can see during the treatment, and maybe the next day I can see the necrotic tissue, because on the surface, you know, it works very quickly. With this ICG, it seems to go more slowly, and that's of course very comfortable for the patients.
Yeah, that's very good.
Yeah. But I have to admit, we are just on the beginning. It's a new therapy, and of course we treated maybe about 150 people. That's already a big amount, but in the last 7 months, and we have not yet evaluated the whole potential. The only thing what I can do, I have a lot of experience. We treated so many patients in the last 5 years, and you get some experience, and I cannot deliver you a lot of statistic data in the moment, but I know from experience that it's a great chance for the future. And I hope we need, of course, more centers, you know, and I hope Peter Dorscher, he knows everything what we are doing, and I hope I can convince Mayo Clinic maybe in America to follow us. And we have a big university close to Frankfurt, is Marburg, where I made my diploma in biochemistry, and the whole department of pharmacology, Professor Barkowski, the whole department is working on ICG at the moment. They're all crazy about this therapy. So we have good universities on the side, because we need the basic research. We have to know exactly the pharmacokinetics. How long will it take to go in this tumor, maybe in a brain tumor? There are many things what we still don't know exactly. Yeah.
Right. And the other question I had was not about PDT itself, but in the cellular immunotherapies. You talked about dendritic cells. You may have heard about some studies on effect of lasers on dendritic cells and T cells.
Yeah, there is one the biggest institute for immunotherapy is close to Göttingen, very close to us. They have hundreds of patients every month from all over the world, and they work specific with dendritic cells from patients' blood, make some specific vaccinations. In the moment they send all patients before their therapy to us to make the PDT first, and then work with the dendritic cells. And they are performing a great study in the moment. So I think we will get results from some 100 patients end of the year, how this works together. Okay, then thank you very much for your attention.
Thank you, Dr. Weber. That was interesting. Let me introduce the next speaker of the day. Is Jerry Ann Lyons. Jerry is a PhD in immunology and microbiology. Then she went on to do her postdoctoral research faculty of Washington University School of Medicine, Department of Neurology. At present, she is a faculty in Biomolecular Sciences, University of Wisconsin, and an associate professor with the College of Health Sciences, University of Wisconsin-Milwaukee. She has over 26 years experience in animal models of multiple sclerosis, 19 years experience in the human system of multiple sclerosis, 10 years experience in photobiomodulation, and today she's going to talk to us on the application of photobiomodulation to the central nervous system disorders. Welcome, Anne.
cursor just went away. Oh, thank you. Except that now it's not up there and I can't. This way? No. No. Oh.
Where is it? It's not showing here. The keypad is not showing.
You've got your...
Yeah.
You've got your...
Slightly.
Right, so you can take it from here then. Just play. You've got the dual screen.
Okay.
Good. And you've got the next slide up, which is nice.
Wonderful. Thank you. Good afternoon, and thank you all for being here today. I'd like to thank Dr. Murthy and the organizers for the opportunity to present here today. I'm going to be talking about the therapeutic efficacy of photobiomodulation for autoimmune demyelination, but also a little bit in the other CNS applications of photobiomodulation. So we've heard some about therapeutic applications for central nervous system disorders of photobiomodulation over the last couple of days. Certainly traumatic brain injury and transcranial photobiomodulation is showing good promise. There's been some efficacy in stroke and spinal cord injury. Today I'll spend a little bit of time on more recent studies of Alzheimer's disease and cognitive impairment, as well as Parkinson's disease, and then finally multiple sclerosis. Now, the important thing to note with these diseases is they are in large part still in the animal models. And it's been slow to move to the clinical conditions, partly perhaps because it is PhD researchers like me and not MDs working on this. I think there needs to be some collaboration between the researchers and the medical doctors to move these to clinical studies. But also, as I'll show you a little bit later, I think there's some things that we need to be concerned with as we move forward in the application of photobiomodulation for central nervous system disorders. Now, with the central nervous system disorders and neurodegeneration, they do share mechanisms of disease that really do lend themselves quite well to photobiomodulation. And it's important to note that these mechanisms are not mutually exclusive. We know that with Alzheimer's and Parkinson's disease that there are associations with genetic mutations. For example, with Alzheimer's disease, perhaps in the beta amyloid, in Parkinson's disease, particularly in genetic forms, and in our animal models, alpha-synuclein, Parkin, for example. Now, with the animal models as well as with human conditions, a lot of times these are toxin-mediated. For example, Parkinson's disease induced with MPTP, which is neurotoxic, both in animals and in people. But there's an ever-increasing appreciation for the role of the immune response in neurodegenerative disorders, not just autoimmunity like multiple sclerosis, but there's been an increased appreciation for the role of the immune response in Alzheimer's and in Parkinson's disease. Now, sometimes this is recognized at first just by the normal function of the immune response as macrophages infiltrate for phagocytosis to clean up the damage, but this is going to set up an inflammatory response within the central nervous system, which we know is toxic to the axons, the myelin sheath, the oligodendrocytes. There's also a role for mitochondrial dysfunction in neurodegeneration, reactive oxygen species and reactive nitrogen species. Many of our animal models of Parkinson's disease, for example, with alpha-synuclein, there's evidence for a role of mitochondrial dysfunction. In multiple sclerosis, as patients progress from early relapsing remitting disease to more progressive disease, or perhaps they are progressive from the onset, we know that that accumulation of neurological disability is due to oxidative stress to the neurons, the axons, and therefore and then eventually to the loss of those and the oligodendrocytes. And as we've discussed over the last couple of days, some data that I will show you, these are mechanisms that photobiomodulation is able to intercept. Now, one of the issues with treating central nervous system disorders with photobiomodulation is the size of pathology of these diseases. We know penetration of light could be a problem. So on your left, cartoon showing the sites of pathology for Parkinson's disease and Alzheimer's disease. Alzheimer's disease outlined in the green area lends itself, it seems, quite readily to perhaps transcranial. It's more cortical or subcortical, more surface structures of the brain, whereas with Parkinson's disease, this is a deep brain structure. The brain stem, the substantia nigra, and in studies it seems that perhaps we're going to need to more directly access that brain structure if direct interrogation of the lesions by the light is necessary. I apologize for the quality of the image on the other side. Multiple sclerosis is further complicated by the fact that these lesions aren't particularly isolated to one particular part of the central nervous system. We have lesions in the brain, we have lesions in the spinal cord. These come and these go with the disease by the very definition of multiple sclerosis. Lesions come, lesions go. It is a disease of the white matter, and one of the first steps perhaps in the application of photobiomodulation for the treatment of multiple sclerosis might be the optic neuritis, the inflammation and demyelination of the optic nerve, which is very common in these patients. So whereas with Alzheimer's and with Parkinson's disease, we do have areas that we can more specifically target, multiple sclerosis perhaps is going to require a broader application of light. Now, we know that penetration of light depends on the wavelength. This is a study in rats from 2014 showing that if we go through the skin only, this is the dotted line on the top, we have fairly good penetration. If we go through muscle only, the dotted line in the center, a little bit less. We put the skin and the muscle together and we see a great decrease in the penetration of that light. Certainly at the lower wavelengths, with deeper penetration as we move forward towards 800 or 900 nanometers. Now, in this same study, they looked at the penetration. This is LED light at 670 nanometers, as well as 830 nanometers. And we see that when at 3 centimeters, where the light is being applied, the dotted line is the peak. But when we look at the level of the spinal cord, we see great attenuation of that signal. These are rats. When we think about applying this to the human condition, again, we're going to have to think of ways to get that light to where it needs to be. Either perhaps fiber optics, intranasal is another possibility that might work for some of the deeper brain structures. Now, just briefly, Alzheimer's disease, relatively new application for photobiomodulation. The first published paper in 2012 by Summers et al. This was a cell culture study in which they used a neuroblastoma cell line that they loaded with fluorescent beta amyloid and then treated with the light to measure the clearance of that, the clearance of the beta amyloid by the cells. And what they saw was in the light-treated cells, increased cell survival, increased ATP content, and decrease in the beta amyloid. Now, more recently, there has been development of animal models of Alzheimer's. These are recent. The first studies published in 2011. 2011 was the first study there. And regardless of the mutation that they studied, they did see clinical improvement. They saw clearance of the beta amyloid or a decrease in the beta amyloid plaques, as well as some of the more mechanistic aspects of disease, for example, oxidative stress. The study by Taboado et al., they also saw a decrease in inflammatory markers, again, showing some promise for the treatment of Alzheimer's disease. There have been only a few anecdotal reports of photobiomodulation in Alzheimer's disease. So this is an untapped market that really could benefit the patient because there aren't any effective drugs really for the long-term treatment of Alzheimer's disease. Now, Parkinson's disease has lent itself much more readily to studies of photobiomodulation, as you can see by this table here. And this is both in toxin-induced models such as the MPTP, as well as in transgenic animals. And over a wide range of studies, various wavelengths, there's again seen efficacy of photobiomodulation in these systems, both with the preservation of the dopaminergic neurons as well as in their activity. So again, there have been one clinical study reported. However, it wasn't randomized, it wasn't blinded. Again, we need some high-quality clinical studies done to validate the use of photobiomodulation for Parkinson's disease. With Parkinson's disease, there are a couple of therapies that are relatively beneficial early on. For example, dopamine agonists. However, with time, they lose their efficacy and patients progress. All right, this brings me to multiple sclerosis. Now, multiple sclerosis is an inflammatory disease of the central nervous system. It's considered autoimmune in nature. The signs and symptoms depend on the location and the size, as well as the number of lesions, also referred to as plaques. And you can see these on MRI as active areas of inflammation, particularly early in disease. It used to be considered that axonal damage didn't occur until later in disease. We now know that's not true, that we start accumulating axonal damage relatively early. Now, the initiating event is the demyelination of the axon. And there are a number of factors that contribute to demyelination. Certainly in the inflammatory response itself, we know, for example, tumor necrosis factor alpha, directly toxic to the myelin sheath as well as to the oligodendrocytes. The inflammatory response itself, the generation of the reactive oxygen species, the reactive nitrogen species. Now, in most patients early on, we can repair this damage. And with this, the myelin sheath is repaired enough to function, not back all the way good as new, but with time and the death of the oligodendrocyte responsible for synthesizing the myelin, the axon goes unprotected. We get an accumulation of reactive oxygen and nitrogen species associated with mitochondrial dysfunction, and then the dieback of the axons and the permanent accumulation of disability in our patient. Now, when we look at the pathogenic mechanisms of multiple sclerosis, it really is a nice paradigm to study photobiomodulation in, because we have a role of the immune response early in disease, and then later in disease it does transmit more to oxidative stress. Now, it's important to note that there are two main forms of multiple sclerosis. One is a relapsing remitting disease in which patients will experience an attack of clinical signs or symptoms. They'll recover for a period of time and have a subsequent attack. Each of those attacks is associated with immune infiltration of myelin-reactive T cells into the central nervous system, and that is mediating the damage that we see, leading to the clinical signs and symptoms in our patient. Now, as disease progresses and the patients move into a more progressive phase with accumulation of disability, the immune response in large part is absent. We see very little evidence of inflammation, but here's where the accumulation of oxidative stress, mitochondrial dysfunction come more into play. Now, there is a subset of MS patients that don't experience relapses. They present with clinical signs and symptoms. They only progress in their disease. They never recover, simply referred to as primary progressive MS. Now, with the relapsing-remitting patients, we do have therapeutic agents that are effective at controlling the immune response, at least for a while, but they don't offer neuroprotection and they don't act on the oxidative stress. There are no clinical agents approved for the treatment of secondary progressive MS or the primary progressive MS, and this is where photobiomodulation would hold some promise. So initial studies done in the experimental autoimmune encephalomyelitis model of EAE. I know some of you have heard this before. This too is an inflammatory demyelinating disease of the central nervous system. It recapitulates many of the clinical signs of multiple sclerosis, the pathogenic mechanisms of multiple sclerosis. It's important to note that it is not a spontaneous disease. We actively induce animals with typically one of three myelin proteins: myelin basic protein, proteolipid protein, or myelin oligodendrocyte glycoprotein. The protein that we use depends on the strain of animal that we are studying, and each of these, they present with different clinical courses. For example, the data that I'm going to show you today are C57 black 6 mice immunized with myelin oligodendrocyte glycoprotein, which induces a chronic form of disease, whereas if we immunize SJL or white mice with either myelin basic protein or proteolipid protein, they present with a relapsing-remitting disease. And with these different clinical presentations, they're considered models of disease at that stage in our MS patients. So the model that I'm working in right now is a more active, more later stage disease than is the early relapsing-remitting. So again, these are B6 mice immunized with the immunogenic MOG 35 to 55 peptide. For treatment, it is a total body irradiation. They're placed into a polypropylene chamber, and the light, and the light is applied directly over them. At 5 joules, the delivered 5 joules per centimeter squared, we've used 3 wavelengths: 670 nanometers, 728 nanometers, and 830 nanometers. The selection of these wavelengths were based on the absorption spectrum and action spectrum of cytochrome C oxidase and the near-infrared light. And then we quite simply compared the disease course between treated animals and sham-treated animals. Now, we tried a number of different protocols. Early on, we tried just a simple suppression protocol where with the day of immunization, we started treating animals for 10 days, and we had a temporary effect, but we saw that that effect was lost after about 20 days or so. And so we developed a treatment protocol such that we started treating animals at the day of clinical onset, treated for 7 days, let them rest for 7 days, and then treated them again. And in this way, we were able to get a lasting improvement of clinical disease in our animals. Now, as I said, one of the biggest issues with therapeutics for progressive MS is none of the agents on the market offer any neuroprotection. So we were curious to look at apoptosis in these animals. such that we did tunnel assay on spinal cord sections isolated over the course of disease. The top two panels, A and B, are isolated 2 days after the initiation of treatment, thus 2 days after the onset of clinical signs in our animals. Panels C and D were isolated at peak disease, and then finally the bottom two panels isolated 2 days after the initiation of the second treatment, which typically was associated with a relapse. And simple microscopy counting of tunnel-positive cells showed that throughout the disease course we had, an improvement or fewer apoptotic cells in our treated animals than in the sham-treated mice. In this case, sham was simply restraint stress without the application of light. What was interesting is, now we have not had a chance to phenotype these cells. Using the precipitating tunnel assay, it's hard to do the double fluorescence to phenotype these cells. But what's interesting is, if you note, in the first four panels, these apoptotic cells, or the brown color, are concentrated in the lesions, the pro-inflammatory lesions of these animals. These could be mononuclear cells from the immune infiltrate. They could be axons or neurons within those lesions. However, as we look more chronic in the disease, again, we lose that inflammation, and now we seem to be finding more cells within the parenchyma that are being protected from apoptosis by the light. Now, what's important to note with the treatment of multiple sclerosis, perhaps other autoimmunity for certain, other neurodegenerative diseases depending on their clinical course, there were treatment protocols that we used that made the mice worse. This was with one of our very first experiments in photobiomodulation. This was back when we were doing the suppression protocol. And the graduate student who was doing the treatment said, well, what happens if we just treat all the way through peak disease? And we said, okay, let's see what happens when we treat through peak disease. And the answer was, we lost our protective effect. So if we treated too long, we no longer protected animals against disease. And it's possible, we didn't repeat this enough times to be absolutely certain, but it's possible that it actually made the disease, the acute episode, worse. Now, one hypothesis as to why this might be is the role of inducible nitric oxide synthase in the disease process, in the regulation of the immune response, and as we saw, what near-infrared light did to the expression of inducible nitric oxide synthesis in these animals. So with the continued treatment of animals with the near-infrared light, we saw a decrease in inducible nitric oxide synthesis and the generation of nitric oxide in our animals. Now, for the pathology of multiple sclerosis, this is a good thing, because this could be part of where our neuroprotection is coming. However, we also know that nitric oxide is critical for the downregulation of the immune response. And so it's possible that in these animals, with the continued treatment and that downregulation of nitric oxide, we weren't downregulating autoimmunity, we were perpetuating it, and perhaps that's why these animals got worse. Now, as I pointed out a few slides ago, we know that, or we suspect, we don't know, we suspect that as we move into human studies, we're going to have to go with a longer wavelength. So we've done a couple of experiments with 830 nanometer light, which has been shown to penetrate deeper into certainly the animals as well as people. And again, what we saw here, so the open circles are 670 nanometer light. The sham is the circles up on the top, and then our 830 is the squares that kind of go between. Now, what we saw was, with the acute episode, again, an increase in disease severity. And then as the mice entered the chronic phase disease, those treated with 830 nanometer light were not protected nearly to the extent of the 670 nanometer treated animals, and statistical significance was very weak. Now, again, we haven't done any mechanistic studies with this yet, don't quite know what's happening, but as we move into clinical studies in patients, I think it's going to be something that we have to have a handle on moving forward. So changing gears a little bit, I want to address the anti-inflammatory effects that we've seen and how we're moving forward with this with some human studies. So just to kind of get us all on the same page, multiple sclerosis, EAE, is a CD4 T cell mediated disease. CD4 T cells are T helper cells. They are defined by the cytokines which they produce. Now, many populations have been identified. These are those that are important to multiple sclerosis. So if we think of this as kind of a balance between the good and the bad in terms of disease, the Th1, the Th17 cells, these are pro-inflammatory. These are pathogenic in multiple sclerosis. In particular, interferon gamma, TNF-alpha produced by the Th1 cells, IL-17 produced by the Th17 cells. On the flip side, we have our anti-inflammatory cytokines, the Th2 cells producing IL-4, IL-13, the regulatory T cells producing interleukin-10 and TGF-beta, depending on what type of T regulatory cell they are. It's important to note that interleukin-10 is actually produced by a wide variety of cells in the body, not just regulatory T cells. We know that from past experience, if we can increase the anti-inflammatory cytokines, decrease the pro-inflammatory cytokines, this is beneficial for the treatment of multiple sclerosis. So early in our studies, we isolated the lymph nodes from our immunized mice, again with the MOG35 to 55 peptide, and cultured these cells in vitro, and then treated them in culture. Now, the way these studies are done, lymph nodes are isolated, single-cell suspensions are prepared, and then they're plated into 24-well plates. 2 hours after the cells are plated, they receive their first treatment. They're treated for 90 seconds. Just the light set on top of the cover of the tissue culture plate. And then once every 24 hours through the course of the experiment, and then we isolate cell culture supernatants, and we look by ELISA for the presence of the cytokines there. And if we take a look here, what we see, the graph on your left is interferon gamma. The closed squares along the bottom are the cells treated with 670 nanometer light. The no light, the squares up at top. 728 nanometer light, in early studies, we did not see a clinical effect with this wavelength. And again, here we see a decrease in interferon gamma, or the pro-inflammatory cytokine, when treating with 670 nanometer light, but not with 728 nanometer light. If, on the other hand, we look at interleukin-10, again, one of our anti-inflammatory cytokines, we see a statistically significant increase in the amount of IL-10 produced by our cultures when treating with 670 nanometer light, but not as compared to no light. And again, we don't see this effect with the 728 nanometer light. If we look in the spinal cord of our animals over the course of disease, over the course of treatment, these studies, we isolate RNA from the spinal cords and then analyze by quantitative PCR the amount of message present. In this study, certainly some look to be significant decreases in interferon gamma over the course of the treatment protocol. However, it did not reach statistical significance in this study, but over time we did, particularly at that later time point. We saw that statistically significant decrease in interferon gamma. We also saw the increase in interleukin-10 as we did in vitro. We also looked at interleukin-4 in these spinal cords. We don't look for interleukin-4 by ELISA because the cells use it as quickly as they make it, and so it's very difficult. Actually, I've never seen measurable interleukin-4 produced in my cultures. What we saw, though, with the interleukin-4 was an increase in interleukin-4 during peak disease, followed by the increase in interleukin-10 at our later time point. And that's important because that interleukin-4 may be playing a role at inducing or at least supporting the growth of the interleukin-10 producing cells. Now, it's great to see message. Message doesn't always mean protein. And so here we looked for interleukin-10 production by lymph node cells from treated animals. This is flow cytometry. On the y-axis in each case is simply side scatter, a measure of internal complexity to help further differentiate these cells, initially gated on lymphocytes. And we can see that with the 670 nanometer light, a significant increase in the number of interleukin-10 producing cells in the lymph nodes of these mice. So we are seeing this effect not only in vitro and by more indirect methods, but also directly by lymph node cells from these animals. Now, just because we see interleukin-10 produced doesn't mean that it's important to our clinical effect. So in this experiment, we used mice deficient in interleukin-10 due to targeted knockout. The graph A is the wild-type animals that you've already seen that clinical effect. Again, this is the B6 model. And in the wild-type animals, we saw the decrease in disease severity with the 670 nanometer treated animals. However, in our IL-10 knockout mice, we failed to see a clinical effect. Again, indicating that not only is interleukin-10 being induced and produced, but it's also important for our clinical effect. Now, as I mentioned a moment ago, one of the sources of interleukin-10 are regulatory T cells. These are cells that can be induced to antigen. They can also be produced in the thymus during regular T cell maturation. They are identified by a number of markers on their surface. They may express either CD4 or CD8. They typically also express CD25, which is the high affinity chain of the interleukin-2 receptor. FOXP3 is a transcription factor expressed in the nucleus of these cells. It's critical for the induction of the T regulatory population in these animals. Although it's important to note that the expression of FOXP3 does fluctuate over time, but if you see FOXP3 expressed, you can be relatively sure that it's a regulatory T cell. Now, we also have the secretion of our cytokines, again, interleukin-10 or perhaps TGF-beta. It's important to note that regulatory T cells can act either through the production of these suppressive cytokines or via direct cell contact to the cell that they're regulating. So when we looked for the expression of FOXP3 in our lymph node populations from our treated animals, these are the two histograms on the right. The red histogram is our sham-treated animals. The blue line are other way around. The red histogram is our 670 nanometer treated animals. The blue line is our sham-treated animal. And we see that with in the middle graph, the induction of the FOXP3 expressing cells in our treated animals. The graph on the first graph is sham with and without antigen. The middle graph is with antigen. Now, when we further gated on these cells, we found that they do express CD4 as well. So they are CD4 positive, FOXP3 positive cells. We need to further investigate these to characterize them as regulatory T cells and to investigate their function in our animals. But it does seem that the 670 nanometer light may in fact be inducing regulatory T cells in our system. So this is all well and good. It's an animal model. We do want to start moving towards human studies. Now, as I indicated a moment ago, we have to have some amount of caution as we do because of the role of the immune response in this disease. And certainly, everything I've shown you thus far is in the chronic progressive model of disease. We have yet to look in the relapsing-remitting disease. So we are in the process of optimizing our system. And really, at this point, we're looking at the effects of the light on isolated peripheral blood mononuclear cells. Blood is recovered from the patient, typically about 30 to 36 mils. Peripheral blood mononuclear cells are isolated over a density gradient, and then they're set up in culture, very much analogous to the mouse system that I explained earlier. We've optimized on activation of these cells with amitogen, phytohemagglutinin. We're also working on optimizing with activation through the T cell receptor with anti-CD3 and anti-CD28. The difficulty in these human studies is going to be getting antigen-specific proliferation. We can't prime people the way we can prime mice. So we're searching for a good antigen-specific marker. We may need to investigate some other autoimmune conditions, for example. Now, when we first did our animal studies, when we looked at the effect of the light on these, we only saw a positive effect when we stimulated the cells specifically with antigen. If we stimulated the cells with a mitogen, in this case concanavalin A or Con-A, we didn't see the decrease in pro-inflammatory, the increase in anti-inflammatory that I showed you a moment ago. So we weren't quite sure what we were going to see in these initial studies that we'd optimized with phytohemagglutinin. So again, whole blood from human donors. We used the same 90-second treatment, and we've looked at the effect of 670, 735, 830 nanometer light. Here you see the parameters. The 67% intensity is our standard treatment protocol. The 23% intensity we were hoping to get, we wanted to have somewhat of a dose response. And so we chose a lesser amount of irradiation. And then again, measuring the cytokines by ELISA. Now, we first looked at interferon gamma, and across the board with either the 670 nanometer light, the 735, or the 830, regardless of intensity, we didn't see an effect on interferon gamma production, which didn't surprise us. Again, these are cells isolated from a healthy donor and stimulated with a mitogen. So we weren't really expecting to see a whole lot, and again, we didn't. If we look at interleukin-10, again, we don't really see much of a difference, certainly nothing statistically significant between any of our light parameters or doses. But we also moved forward to look at interleukin-6 and TGF-beta. These are cytokines that we have yet to measure in our animal model. And as I'll show you in a moment, these are important because their function is dependent on each other. When they're both present, we get pathogenic T cells. If TGF-beta alone is present, we get regulatory T cells. Now here, what we saw, much to my surprise, is at 670 nanometers with the 23% intensity, we may be seeing a statistically significant decrease in interleukin-6 production in the presence of the light early on, 24, perhaps 48 hours after the initiation of culture. But as cultures progress, we lose this effect. However, at the higher dose, we get a more pronounced decrease in interleukin-6 production. And this may or may not be maintaining over the course of the cultures. We're going to have to look further at this. However, at the 735 nanometer dose as well as the 830, we really don't see any statistically significant difference in the interleukin-6 production. Now, we look at TGF-beta, and this is an ELISA, but it's an ELISA that's able to differentiate between the activated and the unactivated TGF-beta. You start by activating, you do the assay in the presence and absence of acid. Acid will activate the TGF-beta, as Praveen explained the other day. We have to cleave the latency-associated peptide to get the active TGF-beta in the cultures or in the animals. And again, at 670 nanometers, early on, we don't really see much of a difference. However, in the middle of the culture period, about 72 to 120 hours, there seems to be a decrease in TGF-beta in these animals. And this decrease is certainly more pronounced at the higher intensity over the entire duration of the cultures. Now, it's important to note with the 735 and 830 nanometer cultures, we don't really see an effect, but I want to point out the axes there. In these cultures, these are two separate experiments, we got much less TGF-beta produced in these cultures, so we're working to repeat this to determine if, in fact, we aren't going to see an effect on TGF-beta. So if we summarize what we've seen in these early experiments, at our lower dose, we see somewhat perhaps significant decrease in interleukin-6 at 24 to 48 hours, which then moderates. We see a decrease in TGF-beta at our later time points. If we look at the higher intensity, we're still seeing that decrease early in the culture in interleukin-6, and the decrease in TGF-beta is over the entire culture period. Now, if we take a look at the role of these cytokines in the regulation or the induction of our various T-cell populations, as I said a moment ago, if we start with our naive T-cell, in the presence of both TGF-beta and interleukin-6, we're going to get Th17 cells. We know that these are extremely pathogenic in our animal model as well as in our MS patient population. However, if we only have TGF-beta, then we can go through that induction of our inducible Tregs, which would be protective in our animals. So one hypothesis, given the kinetics that we're seeing, and again, preliminary data, we need to confirm it, it's possible that with our treatment early on, if we're decreasing IL-6 but maintaining TGF-beta, we may be able to get a head start on those regulatory T cells for a beneficial effect in our animals, and then as those cytokines fluctuate over the course of the disease, they're being sustained by other mechanisms. Possibly. So, in conclusion, the effect of photobiomodulation induced by visible red or near-infrared light differs depending on the wavelength in an animal model of chronic multiple sclerosis. How this plays out in our patient population will remain to be seen. Our preliminary data on human cells does perhaps suggest a dosage effect on at least some of the cytokines that we've measured thus far. Our future studies, certainly dose optimization, both in our cultures, in our clinical model, and the effect of the different wavelengths on the human immune response. We also need to take a look at the efficacy of photobiomodulation in relapsing remitting disease. I think it's important for the safety of our patients that we start this in the animal models. We know that we're having an effect on the immune response. It's possible that photobiomodulation may not be effective early in the disease process. I personally don't think that I don't have a problem with that. We have drugs that are effective early in disease. If we can find something that's effective during the chronic stages of disease to protect these patients from permanent disability, I think that that would be a real boon to the treatment of multiple sclerosis. I think we also need to consider that photobiomodulation, particularly in the relapsing remitting disease, is probably going to be an adjunct therapy. We have standard of care. A number of therapeutic agents have been approved by the FDA in the U.S. for the treatment of multiple sclerosis. We aren't going to be able to do placebo-controlled studies very easily because many physicians place their patients on drug at the time of diagnosis. It's hard to find a patient who's not being treated by drug. And so I think that that's another thing we need to be concerned about because there has been precedent. If you inhibit the immune response too much, that you can actually cause harm or even death to the MS patients, particularly if you're preventing those cells from entering the central nervous system. There was a case with a drug called Tisabri, which blocked infiltration of the immune response into the central nervous system. The problem is it was very, very effective at that, and we lost the immunosurveillance function important for keeping viral infections in a latent state, and patients developed encephalopathy and died. So I think it's going to be important to make sure that as we combine these therapies, we don't have any adverse effects because of that effect on the immune response. Briefly, the people who did the work acknowledged Dr. Janice Ells. Without her, none of this would have been done. First experiment we did, I did not expect to work. That was 10 years ago. Actually worked quite well. I think it was very serendipitous. Our light sources provided, at least initially, from Quantum Biomedical with funding from University of Wisconsin-Milwaukee. And with that, if there are any questions, I'm happy to answer.
Is this teacher beta 1 or
Sorry?
have you looked at the other isoforms? Beta 2 and beta 3?
Just beta 1 at this point.
It's a wonderful presentation. It's right here. Question I had was, if you're going to take it to the humans, where are you going to treat? How are you going to? What do you think you're going to do for them? Whole body is what you do for animals. And second question is, it is a chronic model, but are you looking at remyelination in this case? Your data only talked about immune regulation.
Something that you can see in multiple sclerosis patients as well.
Oh, thank you.
I just want to say thank you. That was really, really interesting. First point is that it's really kind of exciting to, at least preliminarily, think that laser might induce like more Treg proliferation and less Th17. You know, because that has lots of ramifications for every autoimmune.
For a lot of autoimmunity.
Not just MS. We're talking RA, Crohn's, like
Absolutely.
everything. So that's really exciting to see that that might be possible. And so the question is, do you think it might be, so if you're doing like say blood irradiation through like transcutaneous through the, at the wrist or something like that, do you think that might be a possible target, target to get circulating blood cells?
I do, and certainly we do see we see strong effects on the immune response, and I do think that there's going to be a certain amount. If we can simply downregulate inflammation, we're going to offer at least some level of treatment to the patient. It's important to note, though, that the oxidative stress that's occurring in the central nervous system is independent of the regulation, the inflammation. And so even with time, even if we're controlling inflammation, we're still going to see some disease progression. So I think that in certainly treating the blood, inducing the anti-inflammatory immune response is going to be beneficial. But again, I think if we want that neuroprotection, we're probably going to have to access the central nervous system directly.
Thank you.
All right. Thank you very much.
You got it? Let me just fiddle with it a bit. No, it's just... I shall introduce myself. It's me again. Hooray! What was that? Oh, good. I'll tell my wife. Okay, photobiomodulation therapy, treatment of oral mucositis and other cancer therapy side effects. Just in case you don't know about cancer therapy side effects, chemotherapy, radiotherapy, hematopoietic stem cell transplantation can be really toxic. Not just to cancer cells, but to other tissues as well. So in these examples here, you can see some examples. An example of oral mucositis here, radiation dermatitis for head and neck cancer patients, and it can also affect things like salivary glands as well. So the cancer therapies can cause inflammation, tissue necrosis, you lose function, you can develop peripheral neuropathies and, of course, pain. And about 10% of patients want to withdraw from radiotherapy treatments because the side effects can be so severe. Now, one of the things, of course, we all know from light is that we can use it to these tissues are stressed, they're going to be low on ATP, they're going to be high in oxidative stress, and then we put light of the correct wavelength and intensity into the patient, then we can tip the balance in favour of more ATP and less oxidative stress. And then we end up with some happy cells. So there's one of Mike's slides here saying the same thing really. Light in here displaces nitric oxide. You get changes in ROS and ATP, which affect ultimately NF-kappa B, which is known as the master switch for inflammation here as it translocates into the nucleus. But it seems that when we put light into these patients, that this seems to be reversed in some way, and somehow AP1 cyclic AMP plays a role in the resetting of NF-kappa B. Somebody's done a trial on this to investigate the role of modulating NF-kappa B with light in oral mucositis. And if you want to study these things in more detail, you can look and see how cyclic AMP can inhibit the activation of NF-kappa B. And Michael, I've just sent you the paper on that, so you can look that one up. But before we talk about treating the cancer therapy side effects, a lot of people are concerned about what light might do to the active cancer. So just a quick look at cancer safety. So back in 2010, the North American Association for Laser Therapy had a consensus meeting on safety and contraindications. Praveen, it's time we had one of those again, I think. Update this, I think. On the list, of course, was cancer. And we said at the time, do not treat directly over the site of any known primary malignant carcinoma or secondary metastases. And with an exception, except for palliative care with informed consent and oncologist permission, perhaps for treating pain in terminally ill patients.
And you're using laser for reducing oral mucositis?
Yeah, and skin dermatitis during and after radiation therapy and combined treatments.
Okay. These patients have cancer, and a lot of people will be concerned that maybe laser therapy would be contraindicated on patients with cancer. Does this worry you, and if not, why not?
Yes. I'm not worried at all when we have treatment of this cancer. During cancer treatment with chemoradiation or surgery post-radiation, the negative effect of low-energy laser is very low, comparing with our very hard treatment. So we have no concern for patients during treatment. Of course, if you have a patient with big tumors without any treatment, and you do laser for palliation on the tumor, that will be some risk of increasing the tumor when you treat on the tumor in itself. But when we have treatment for all the general condition with chemoradiation or surgery plus chemoradiation, the negative effect of low-energy laser is very, very low regarding comparing with those treatments, and so I have no concern for patients during the treatment. And in the same feeling, when we have post-operative setting, of course, no tumor is inside, we have just perhaps microscopic disease, and for microscopic disease this negative effect is totally absent, not at present. So we have no concern about that, especially for people during chemoradiation or radiation alone.
Good, thank you.
So René Jean's been treating cancer patients since 1993 with low-level laser therapy. So perhaps next time we revise this, we will be able to say something like, and for treatment of cancer therapy side effects as an exception, but only when patients are undergoing chemotherapy or radiotherapy. This is not yet a null statement, but hopefully it will be. But let's just look at a couple of examples where things go wrong with light and cancer. So in this study here, this is an in vitro study. These melanoma cells here are going to get treated with red light, 2,500 milliwatts per centimeter squared, so that's a lot. It's very high irradiance for a cell study. For 1 minute or 7 minutes, that's 150 or 1,050 joules per centimeter squared. Now, if you compare that with treating, superficial inflammation like oral mucositis, where we'd be dealing with low single figures, 1 to 4 joules per centimeter squared, then this is a very high dose. 3 consecutive days, what happens? This is looking at cell death here in a control group, but in the 1 minute and 7 minute treatment groups, we seem to be actually killing cancer cells. And you think, well, hooray, we're killing cancer. But when you put it into a mouse here, these melanoma cells, exactly the same treatment plan, 1 minute or 7 minutes, 150 or 1050 joules per centimetre squared. There's tumour volume in the control group, there's tumour volume in the 1 minute treatment group. There's not statistically significant, that reduction, apparent reduction in the melanoma, but on the 7 minute group, definitely we have a significant increase in the tumour volume of this melanoma. So now it seems we can increase tumour growth with light, with a certain set of parameters, we should say. And take the other opposite end of the scale, very low irradiance study, 8 milliwatts per centimetre squared, compared with 2,500 on the last study. For just 5 minutes and 12 seconds, 5 joules per centimetre squared, well within the normal range for treating oral mucositis twice a day for 30 days. This is a non-melanoma, so this is UV-induced skin cancer here, and then looking at the tumour count here, there's no significant difference between these groups. That's the control group, and there's the active treatment group in terms of tumour count. So having no adverse effects in this particular model. They did make an interesting observation. They said that on day 30 and 37, the healthier behaviour was observed in the red light treated group than in controls. The treated mice moved normally, demonstrated normal posture, and exhibited active grooming, feeding and drinking, whereas the control mice showed typical sickness behaviour, including a semi-collapsed posture, shivering as a sign of being cold, lack of movement and lack of grooming. So that's interesting. But these studies and many others like it do not include chemo or radiotherapies with them. I mean, there's so many studies where they can show either no adverse effects, maybe some suppression, but sometimes stimulation of tumours in cell studies, in vivo studies, but they're all being done without any chemo or radiotherapy, with a couple of exceptions. So here's a study I got dragged into after they'd actually finished doing the work to help them with their parameter reporting. So effects of pre-radiation exposure of low-level laser therapy of normal and malignant cells. So first of all, looking at the normal TK6 lymphocytes here, a control group untreated without gamma radiation, without photobiomodulation, but then 50 centigrades of gamma radiation, of course, is now killing the cells. And this is healthy cells. These are TK6 lymphocytes. Give them photobiomodulation, we have good growth of cells. Give them photobiomodulation and followed by 50 centigrades of gamma radiation, and we seem to be protecting them compared with where they'd had no low-level laser therapy involved. Well, that's interesting, isn't it? But what if photobiomodulation, low-level laser therapy, what if that protects cancer cells? Let's see what happens. So, control group again, these are HL60 leukemia cells. Here, in the control group, 50 centigrades of gamma radiation, they're dying, give them photobiomodulation alone, that seems to be killing them as well, and photobiomodulation and 50 centigrades of gamma radiation combined seem to be having a synergistic effect in this study. There's been a couple of follow-up studies on patients who've been in clinical trials and treated with light. So in this one here, this is what's his name? Neil Pillar, who was supposed to be speaking at this event, treating patients with post-mastectomy lymphedema. So they've had a breast removal, they've taken out the regional lymph nodes, the limb sometimes doesn't drain properly. Looking at the breast cancer patients here who did not have any laser treatment, 1,298 of them, and then compare that with how many of them had a reoccurrence of their cancer, 51. How many patients had this lymphedema treatment with low-level laser and manual lymph drainage combined? 52 of them. What was the reoccurrence? It was 3 patients, and the statisticians do their bit. here, and they conclude that treatment of lymphedema consisting primarily of low-level laser and manual lymph drainage does not impact on cancer reoccurrence. This is the long-term follow-up of patients who were involved in an oral mucositis study that had low-level laser or placebo treatments. This is 47 patients in each group, followed for 48 months here, and this is the survival of the low-level laser therapy active group compared with placebo controls, but the statisticians say it's not statistically significant. But I'm glad these lines are this way around and not the other way around. So at the moment, most of the studies looking at cancer in the lab are in patients, in cells that are not going through chemo or radiotherapy, and same with animal studies. We need more of those more clinically relevant studies, and there are more coming. I'm getting involved in some of them. So let's talk about the clinical evidence for treating oral mucositis. So these patients who've had hematopoietic stem cell transplantation, these are the 5 grades of oral mucositis, obviously 5 being the worst. The grey bars represent the placebo group, the dark bars represent the active treatment group. And you can see that the placebo group have far higher grades of oral mucositis compared with the active treatment group, where most of the patients are in low grades or in no oral mucositis at all. And here's a head and neck cancer study looking at these are pain scores here. Here's the placebo group, the level of pain reported compared with the active treatment group, which is far lower. And as I said earlier, about 10% of patients want to give up their radiotherapy because the side effects are so severe. And it's not just oral mucositis they get. They have swallowing problems, so dysphagia. The radiotherapy can affect the musculature. The oral mucositis not just in the mouth, it can be in the oral pharynx, it can be down into the esophagus as well. So the inflammation and ulceration alone makes it painful to swallow, but you've affected the muscles in the neck as well. So problems swallowing, they're not making enough saliva, or they're not making the right kind of saliva, so they're having hypersalivation or xerostomia, again makes swallowing more difficult. And of course they've got radiation dermatitis as well, sort of around their neck. Breast cancer patients had lymph nodes removed, and there's also another side effect from hematopoietic stem cell transplantation, which is graft versus host disease. All of these can be treated with light. So back to here, oral mucositis after treatment seems to be reduced or going away completely in this particular patient. Radiation dermatitis before and after, and dry mouth. Imagine that, where your salivary glands are so damaged that you end up with a dry mouth, not just while you're going through the chemo or radiotherapy, but for the rest of your life, waking up every day with a dry mouth. And this poor kid has GVHD, so many months and years after stem cell transplantation, you can end up with these side effects, and there is no proven effective treatment for it. But this kid went for twice a month treatments to his tongue, with LED light being projected into his mouth, and you can see a significant reduction. The treatment plan typically would be more like twice a week rather than twice a month, but he lived 4 hours away from the hospital. It wasn't easy for them to get in that often. But it's a very important benefit for this one, and there is a paper coming out on this, a series of cases of GVHD and light. So another cancer therapy side effect I've already mentioned is post-mastectomy lymphedema, so where the regional lymph nodes have been taken out and they get swelling in their arm and dysfunction as well. So here showing that the improvement in circumference in the active treatment group is shown here, and they have improvements in shoulder abduction and shoulder flexion and grip strength as well, and that's treatment 3 times a week for 3 weeks in this study. And there's been a systematic review showing that there's moderate to strong evidence for the effectiveness of low-level laser therapy for the management of breast cancer lymphedema, breast cancer-related lymphedema from 5 small studies. I took a photograph at a conference where somebody showed what happens when you put light on lymph nodes here. So they inject carrageenan into the paw of a rat, causes swelling in the paw of the rat, and then they either give them, here's the swelling shown in the red line, then they give the rats diclofenac or diclofenac or laser treatments, and you get a reduction. Well, what makes the study interesting is they did not put the laser beam on the swelling. They only put the lasers around the regions of the lymph nodes. Treating lymph nodes alone reduced inflammation and edema equal to diclofenac induced by, or inflammation induced by this carrageenan. And they did a preconditioning study. So they pre-treated the lymph nodes and they got the same result again. And that leads me to talk to you about this. So pre-treating healthy tissues that we brought up yesterday can actually protect cells or protect your tissues prior to some kind of insult. In this example here, it's ultraviolet light. So increasing amounts of ultraviolet light causing more and more erythema here in the skin. It's quantified here on this chart. But on the left side here, this group here has light-emitting diode, LED treatments, prior to the ultraviolet radiation, and you see a reduction in the erythema, again quantified on this chart. So somebody's done this in cancer therapy patients, they're having radiotherapy, they are IMRT specifically, and even though it takes many weeks before IMRT starts to produce the side effects of radiation-induced dermatitis, they get LED treatments with every IMRT session for, and about 3 weeks into the IMRT treatments, normally you would start to get all this radiation dermatitis. Most of it here is in group 2, a grade of radiation-induced dermatitis. The active light therapy group, though, here are on grade 1 mostly, or none at all, just by pre-treating in advance of any symptoms. Pre-treating healthy tissue helps protect it. So those are some examples of how you can use light in cancer therapy. Side effects, how do you do the treatments? Well, there's 2 great papers out here by JZ, Judith Zika here, et al. A large group of experienced cancer therapy side effects specialists here. 2 papers. There's part 1 on the mechanisms of action, dosimetry and safety considerations, and part 2 here is all about the proposed applications and the treatment protocols. Well worth downloading if you're planning to treat these kinds of patients. It includes lots of illustrations on how to treat and the dosimetry as well. Here's some actual pictures of treatment here, projecting light here into the soft palette and the hard palette here. The guidelines seem to suggest you may need to do about 12 points inside the mouth. Red light here, 13 milliwatts per centimetre squared for 60 seconds, 1.8 joules per centimetre squared. There's 12 minutes. That's quite a long time to be poking around inside somebody's mouth. At our feasibility study we did at Harvard with Dana-Farber, here we are doing extra-oral treatments now. So through his cheeks into his buccal tissues, we're doing through his lips, of course. We're treating submandibular lymph nodes as well to improve drainage, and the cervical lymph nodes as well. Now, nobody's really talked about dosimetry much in terms of doing calculations, so if you don't know how to do it, I've got a website where we actually have a calculator built into it. So you go to the, you go to the research tab on our website here, and then you can go down to dosage calculator, and you end up with all the fields you need to calculate dose here, and you just put some numbers in. So 75 milliwatts worth of laser at 50 milliwatts per centimetre squared, is that what it says? And there's the area of the beam, and then you put in you want 3 joules per centimetre squared. It'll tell you how long to do it, and it'll give you the answer in joules as well if you want it, if Juanita lets you have it anyway in joules. And we also have at our website a treatment library as well, where you can either just click on list all the human issue things, and then you can look up all the different pathologies. You might want to click on cancer therapy side effects. I think it's in here somewhere. Can't even see it. Is it up there somewhere? Oh, there, cancer therapy side effects, and that gives you a whole list of ways of treating, or you can just type in something like oral mucositis here, and you end up with a treatment plan that looks like this, a mixture of extra oral and a few points inside the mouth as well. And you need a special treatment library code for that, so we issue those. If you want to write to me, I'll send those out to you. This treatment now for oral mucositis has been reported in 32 different controlled clinical trials now, from the different causes, so radiotherapy, chemotherapy, hematopoietic stem cell transplantation as well. So it's in the guidelines. So the Multinational Association of Supportive Care in Cancer have got a recommendation statement out for low-level laser for these side effects. And there's one more thing I wanted to mention. Oh yes, the American government, or the future president of the United States of America, of course we don't know who that is yet, but all the candidates are dead keen for low-level laser therapy to be used on cancer patients. Trump says, you're going to love it. We paid Hillary to say she supports it as well. And Bernie will actually pay every doctor $1,000 for every single treatment you give to a cancer patient. Thank you very much. There's my email address if you want it. There you go. And you can get a treatment, you can get a code to get into our library. Any questions? And by the way, well done for staying to the end, almost to the end. It was that good, all right, okay. What did I do wrong? Well, thanks for your encouragement and your being my conscience, of course, for the last decade. And you may say, well, I'm very disappointed you're not even better if that's the case. But anyway, thanks for your leadership and your support.
You're wonderful, interesting, as always, every time. Welcome. And adding to Juanita, I think Peter and Weiss and Leonardo Longo should also come up with some kind of structure on how clinicians should be able to use this and make it far more authentic. Well, it's been a lot of high-level laser information down our systems for the last 3 days on low-level laser therapy. And as we bring curtains down, it's been a wonderful and real pleasurable journey for the last 3 days. Such a lot of diverse topics, such a lot of diverse views, and the communication has been really interesting. I now request Dr. Srinivasa Murthy, Chairman of the Global Summit on Medical Lasers, to come in for a vote of thanks. Thank you. Welcome, sir.
My dear respected eminent speakers who have come from different parts of the country and different universities, and my colleagues and my friends and associates. This is the first of its kind in this country that we plan to have a conference on Global Summit on Medical Lasers and Regenerative Medicine. Even though we come to a conclusion of the 3 days, I consider it as just a beginning for the new revolution in this country. It seems that in India, we need to educate people first to have them laser education. This is the conclusion that we have drawn yesterday in presence of the Guruji. Our next GSML 2017, we plan to prepare and pre-educate them to get themselves educated in the conferences. With the help and support and guidance of all you experts, we design a new model, new method of conference, how to go about the general presentations as well as the workshops, as many of you, the people have suggested to us. First and foremost, we need the people formal education on lasers. So with this, I want to thank each and every one of you who came all the way from different countries and taken trouble and faced all the problems which we gave you and educated us very well. I thank all the speakers, one and all. Thank you very much. And then I thank our event management people and then our live webcasting people who helped several thousands of people beyond this conference hall to watch. I thank one and all. And then I thank my associates, Mr. Giridhar Gopal and then Nayana Niranjan and my other associates in Indian Association for Laser Therapy. Thank you very much, and let us have a tea session. Thank you.